In this video, we will describe a quadriceps tendon turndown for the treatment of chronic quadriceps tendon insufficiency. The authors of this study have no relevant disclosures. The patient is placed supine on a standard operating table, and the operation is performed using a midline incision. When possible, the patient's prior anterior knee incision is reutilized. Sharp dissection is carried down to the level of the quadriceps tendon and retinaculum, and full thickness flaps are developed both medially and laterally. The tear site is identified and debrided back to normal, healthy tendon edges. Next, the central aspect of the quadriceps tendon is identified and a three-sided tendon pedicle is demarcated, ensuring that there is at least 1 to 1.5 centimeters of pedicle width. The pedicle extends from roughly 1 centimeter proximal to the distal end of the tendon stump up to 4 centimeters proximally, depending on the size of the tear defect. It's important to ensure there is 5 to 8 millimeters of tendon on both the medial and lateral sides of the turndown graft. The pedicle is cut full thickness using sharp dissection. A number 2 orthocord suture is placed in a figure of 8 configuration at the proximal corners of the turndown to prevent propagation of the tear. This is repeated on both sides. Two fiber tape sutures are then passed in Krakow fashion along the medial and lateral sides of the pedicle. The donor site from the proximal quadriceps tendon autograft can then be incorporated into the Krakow suture as demonstrated here, or it can be repaired with interrupted number 1 vicryl sutures in a side-to-side fashion. The superior pole of the patella is then denuded of soft tissue, and a high-speed burr is used to lightly decorticate the proximal pole of the patella to promote healing. The patella is then divided into thirds, and either standard transosseous tunnels or interference-fit anchors are placed at the junction of the medial and central third and the lateral and central third. Seen here is an example of the final construct. Post-operatively, patients are placed in a well-padded cylinder cast and made partial weight-bearing. While not shown here, in select cases, a semitendinosus autograft or allograft can be added to the final construct to increase collagen at the reconstruction site.